Good afternoon, dear colleagues. First of all, I want to thank the World Federation and 2018 organization and the Dental Committee to let me be part of this roundtable with these important speakers. The subject that gathers us today is inhibitor patients with hemophilia and their treatment. This means a real challenge for dentists because this complication represents a great risk of morbidity and mortality even nowadays. Consequently, I think that we as dental care workers have to continue learning and share our knowledge to improve dental care in this kind of patients. These are my disclosures. The objectives of my oral presentation are to report the incidence of inhibitor patients in our region, to show the management of non-invasive dental practices, to show the management of invasive dental practices, and to show the systemic and local protocols. As you can see, I divided all the treatment, the dental treatments, into two groups. The first one without risk of bleeding, and the other with risk of bleeding. In our country, with over 44 million people, patients with hemophilia are only 2,650, approximately 0.06%. And the incidence of inhibitors in pups is 29%. Nowadays, and because of the success of immunotolerance induction therapy, this number is fortunately decreasing. This is our institution, the Foundation of Hemophilia of Buenos Aires, Argentina. It was created in October 26, 1944, and its mission is the study, treatment, and social health for patients with hemophilia. The treatment of the patients with hemophilia is organized through a network with reference medical doctors in general hospital services, which work together. This is important, together. This is the main word, in multidisciplinary teams. Dental treatment means so increased risk of bleeding for patients with hemophilia, much more for inhibitor patients. And like a puzzle, excuse me, dental treatment in them has different puzzle sheets. And we consider that one of them is the main one, and it is prevention treatment, because it involves a group of measures implemented from the beginning with the objective of obtaining preventive habits and approaching the patient to dental health. These steps are the same for all the treatments. In all of them, we must follow preventive measures. Unfortunately, in our population, it is very hard to implement preventive treatment because of the patient's fear of bleeding. This is the reason why sometimes we need to implement different strategies to achieve a better condition during these treatments. Non-invasive treatments can be provided safely in general dental practice, and in the case of the last two, one in red, we need to design a comprehensive plan with general and local measures to achieve a satisfactory treatment without risk of bleeding. The dental treatments detailed previously are implemented in general with dental anesthetic procedures. In connection with the necessity of replacement therapy, in this group we can affirm that buccal infiltration, intrapapillary, and intraligamental injections don't need replacement therapy. On the other hand, the technique that requires factor cover is inferior dental block because of the risk of muscle hematoma and, of course, the airway compromise due to hematoma formation in the pterygoid space. The systemic protocol for invasive dental procedures are the following. All the patients with inhibitors undergoing surgical procedures should be hospitalized for close follow-up. And the patients who develop alloantibodies that neutralize coagulation factor activity may be performed by bypassing agents, and which there are two: recombinant factor VII activated and activated prothrombin complex concentrate. In this slide, we can see the protocol used for dental surgery in both cases. In the case of factor VII activated, recombinant factor VII activated, we have an initial dose with 120 or 200 nanograms per kilo, followed by 4 doses every 3 hours for 90 to 120 nanograms per kilo, and following with 120 to 200 nanograms per kilo every 12 hours for 2 days, and 120 to 200 nanograms per kilo per day during 2 or 3 days. Or we can use FIBA with an initial dose of 100 international units per kilo, 100 international units per kilo every 12 hours during 3 days, and 100 international units per kilo during 3 days. We can also use as a way to reinforce this protocol antifibrinolytic agents, and should be started the night before the procedure and continued every 6 or 8 hours for 7 days in the way of mouthwash and then swallow. We can use tranexamic acid 50 to 25 milligrams per kilo, and epsilon aminocaproic acid 2 grams. Please remember that if our patient is treated with FIBA, we can't use tranexamic acid because of the possible thromboembolic complications. Finally, and when the when the surgical treatment requires it, we can use prophylactic treatment with antibiotics like amoxicillin, 875 milligrams twice a day, beginning 1 hour before the procedure. Talking about the local protocol, we can divide it into 2 groups. One of them, previously, as a way to improve the gingival status, and the other, once implemented, once the surgery is done, and we can use the following protocols. In the case of the preoperative, we always suggest the oral hygiene and 2.2% chlorhexidine rinses twice a day, beginning 2 days before the procedure. And as local hemostatic measures, we, in our country, use 3-chloroacetic acid, 30%, and bismuth subgolate. In the case of periodontal treatment, inhibitor patients can be achieved with the conjunction of systemic protocol, of course indicated by the hematologist, hygienic measures, and in the case of this treatment, we can use 3-chloroacetic acid because generally in periodontal treatment, the bleeding is superficial. For example, we can see the superficial bleeding after the periodontal proving or supragingival scaling. But if we make subgingival scaling, probably we can't use 3-chloroacetic acid and can use the other local measure, bismuth subgolate. In the case of dental surgeries, the protocol is the following. Systemic protocol, implemented by the hematologist, of course, hygienic measures, and the selection of bismuth subgolate as a local hemostatic agent. It is a yellow powder, tasteless, odorless, and amorphous, is stable in the air and sensitive to the light. It is insoluble in water and alcohol and has been used in tonsillectomies for its astringent and hemostatic properties. This powder activates the intrinsic clotting cascade by activating factor 12 or Hagemann factor. Its chemical structure bears some relationship with ellagic acid, which is a clot-promoting agent that initiates thrombin generation. We prepare the local hemostatic agent with epinephrine, which is a potent vasoconstrictor. It is used in concentration of 1 in 1,000 or 1 in 10,000 as a topical hemostatic on bleeding surfaces. In addition to decreasing blood flow, epinephrine may stimulate platelet aggregation. We put this product inside the wound and it is prepared as a filler consistency. Finally, our conclusions are: prevention treatment constitutes the fundamental pillar of dental care. It is our guarantee of success. Every treatment can be achieved without complications. We suggest you take special care of soft tissues, of course, and we must highlight the importance of a multidisciplinary team, because we really believe that working together divides the works and multiplies the results. This is our obelisk from Buenos Aires, and as you can see, it is painted in red because of the celebration of the World Hemophilia Day in 2017. Thank you all of you for your attention.